Hello, and welcome to the second installment of Brady's dynamic lecture series covering respiratory emergencies. It will cover the assessment, treatment, transport, and emergency room care of a patient who presents with difficulty breathing. View the program in its entirety, then log on to the online training academy and complete the corresponding exam. If you have any questions regarding the program, please contact Lieutenant Richardson. Case 2. It's 4 a.m., and you and your partner, both paramedics, are dispatched to a local nursing home for reported difficulty breathing. And I know you're already sighing, saying not again, but here we go. Upon arrival, you approach the patient and perform an initial assessment while your partner gets a report from the nurse. On your initial assessment, you find a 91-year-old male sitting upright in bed, pale and diaphoretic. He's breathing about 30 times a minute, and he's on O2 via nasal cannula at 4 liters per minute. Something's wrong with this picture already, and you should be able to tell what it is. What is your initial impression? What would be your initial priorities? Well, first of all, I'm looking at, he's 91 years old, pale diaphoretic, it's 4 a.m., he's wide awake, he's breathing 30 times a minute, they've got him on a nasal cannula at 4 liters. It's going to lead me right into what some of my priorities are. While attempting to talk to the patient, you realize that he has an altered mental status. He's answering your questions inappropriately. 91 years old, you got to think he might be somewhat demented anyway, but still, you view his history and he doesn't know where he is, he's confused, doesn't know his name. Any host of things could give you the clue that his mental status is altered. You note rapid and shallow respirations. When you listen to his lung sounds, you have rales and slight wheezing in his upper lobes bilaterally. You have no air movement to the mid and lower lobes bilaterally. You ask your partner to place a patient on high-flow O2 via a non-rebreather mask. Here you have a picture of that taking place. You also note a strong, rapid, slightly irregular pulse. His skin is cool, pale, and diaphoretic. Additionally, you find that the patient is of normal body mass for his height, but you do notice slight peripheral edema. He does have a history of open heart surgery, and he has pacemaker scars on him. And you also notice a urine-soaked diaper. The vital signs you get, he has a heart rate of 120, and it's slightly irregular. The irregularity is probably not uncommon in a patient of this age, but maybe the heart rate is. But it's still something to file in the back of your head that you're going to want to keep an eye on and watch for further. Has a respiratory rate of 32 and shallow. And he has a blood pressure of 146 over 108, and his O2 sat is 91% on your 15 liters per minute, so you would expect to see a little bit higher there. Maybe if we slow that breathing down, get that breathing under control, get deeper breaths, that might come up. We'll see. What is your differential diagnosis at this point? What additional information would you like? What other vital signs would you like to gather? More clear-cut patient history? What are your next priorities going to be? As you continue your assessment, your partner provides the following patient information that they got from the staff nurse. They say, as far as his present illness, that he's been acting odd for the past few days, more confused than normal. again, we might expect some confusion in a patient of this age, but you know, you got to go with what they tell you, and this acting odd should jump out at you. And that he's not been sleeping at night, which is unusual. My grandmother lived to be in her 90s, and she was one of the people that she went to bed with the squirrels and woke up with the chickens, the way they used to say it. So good night's rest was always important. So that's probably an unusual thing for this guy not to be sleeping at night. He's had mild difficulty breathing that was noted by the staff for about 12 hours, and it's worsened over the past two hours. His past medical history: he has an MI with CABG. You might hear the term referred to as CABG, this coronary artery bypass graft. He has a pacemaker implant 3 weeks ago, and he just returned to the nursing home 1 week ago. Has a history of hypertension, high blood pressure, and he's an insulin-dependent diabetic. So, of course, hopefully you're gathering an AccuCheck at this time, too, just to rule that out. He has frequent pneumonia, slight dementia, and depression. Again, these are all things that we discuss as possible causes, possible things to look out for when we're considering his mental status, rather. His meds include metoprolol, diltiazem, insulin, furosemide, aspirin, and what we know, you may have heard this name a little while in the press, is Wellbutrin, one of those drugs described for people to treat depression. How has the provided information changed your differential diagnosis? Well, if anything, it's given us just a little bit more background into who the patient is. It may have changed some things, but it gives you a better clue as to where we're going here. What are your next priorities? And what additional information would you like? For more detailed assessment, we put him on the cardiac monitor, get IV access, and you hang a bag of normal saline. Finally get that AccuCheck, and it's 84, so that's pretty good there. Not that much of a problem. And we do a 12-lead EKG. All right, so you have a picture here where we starting to employ our interventions, getting IV access, whatnot. Got them on the mask. Detailed assessment part of it, you do a 12-lead EKG, and here's what you see. Think about it, look at it, and what's your interpretation of it? You can see some, maybe note the bunny ears, kind of. That's what I call them. You see in V3 there, and in V4, maybe you got a little bundle branch block going on. Some irregularity. You can definitely see some irregularities in the rhythm there. If you look at your R-to-R intervals in V6 and also in lead 1 and whatnot. Your partner contacts medical control, gives a quick report, and asks to follow your congestive heart failure protocol. The medical physician asks, "How are you sure this is not pneumonia?" Why don't you guys discuss the differences in the clinical findings associated with pneumonia and CHF? What are the dangers in confusing and mistreating pneumonia and CHF? Just a couple to throw out there for you. With pneumonia, you would commonly find fever and chills. Sometimes they have what's called the bed shakes. You'll also have that deep, productive cough. Oftentimes producing like a yellowish sputum, and because of the cough, it almost feels like the rattling in the chest, and causes what's known as pleuritic chest pain. So sometimes people with pneumonia will have that deep cough and that mucus production, but they'll also be complaining of chest pain. So that's something. Of course, we know there are several types of pneumonia: bacterial and viral. One of the reasons that the physician was probably curious was it is a pretty common disease in the elderly patients, particularly those in nursing homes. So it's a concern. And also, remember back to the picture we saw when you're trying to debate whether this is pneumonia or CHF, note that the patient didn't really complain of fever or chills and didn't have a cough or anything for us to pay attention to. And we did also note the pitting edema on the patient, which is a definite or big indicator of congestive heart failure. So those are some of the differences that we can find there in trying to differentiate between pneumonia and CHF. After hearing your partner's argument, the medical control physician gives your orders to follow your CHF protocol. The patient is administered nitroglycerin sublingual, furosemide, IV, or what we commonly refer to as Lasix, and morphine sulfate. A couple of things to remember when we're administering drugs is why we're giving them. Remember that your Lasix or furosemide is a loop diuretic, and it's going to inhibit reabsorption of sodium and chloride in the kidneys. It's also going to cause venous dilation in about 5 minutes after giving it. And this is just, of course, going to decrease the cardiac workload. And it's also going to have a diuretic effect to help remove some of those fluids in about 5 to 10 minutes after giving it. I know over the years our protocol as far as what we administer, how much we administer has changed. So always just stay current on our exact dosage and what we're given. Morphine, this is again going to aid with that Lasix administration because it's going to decrease the myocardial oxygen demand. Again, because this also it's going to decrease systemic vascular resistance, and it has that sedative effect. So it's going to help to calm the patient down. And anytime the patient is calmed down, that's going to help decrease the workload. Because the more excited we get, the more workload and demand we put on our heart. So that sedative effect is going to help calm that down. Your partner prepares the patient for transport as you reassess the vital signs, and you find that you have a slightly irregular heart rate, which we saw in the EKG, and it's also a little bit elevated. He's breathing 28 times a minute and shallow, a blood pressure of 132/96, and his O2 sat's gone up to 92% on 15 liters per minute again, and we have him on the high flow 100% O2, so keep that in mind. You hear no change in the lung sounds. After packaging the patient and obtaining the proper paperwork, you move to the ambulance for transport to the emergency department. You continue your assessment on the way to the ambulance, and you note that the patient appears to be weakening and getting anxious. The patient is using more accessory muscles to breathe. So basically it's becoming harder and harder for him to breathe. He's getting anxious about this, and the two are kind of perpetuating one another, and his condition's just worsening. What additional treatments can you consider? We can discuss the use of CPAP versus endotracheal intubation in this case. And we want to know what advantages we have to each and what the disadvantages, of course. If we go ahead and intubate, we're putting ourselves in a position where we have to mechanically ventilate this patient. And he might not be quite at this step, at this phase. He might be moving that way, but he might not be there. Whereas the CPAP, there are some definite advantages to that. Number one, once we put the machine on, we don't have to, we're free, we don't have to mechanically ventilate. The CPAP device is going to do all the work for us, and it's going to provide a constant pressure. And this may prevent the need to intubate because it's going to, in essence, secure that airway or keep it patent, rather. It's going to force excess fluid out of the alveoli and into the pulmonary capillaries. It's going to fill the atelectic portions of the lungs. Basically, this is going to buy us time. And with CPAP, you're going to get that continuous pressure throughout the course of the entire respiratory phase. So it's going to be of a big benefit to the patient. The biggest disadvantage I can think of, number one, is we don't have CPAP devices on our ambulances. So that's a huge disadvantage there for us. Once in the ambulance, you and your partner place the patient on CPAP if we had it. Of course we don't. Although the patient initially resists the mask, you are able to talk to him during the procedure and secure the mask to his head. Here's a picture. If you've never seen the CPAP, here's a picture of one being placed on the patient. You can see where this might cause a little bit of anxiety. It is kind of an intrusive piece of equipment, but if you can get it on them, it's definitely worth it if we had it. 3 minutes after the application of CPAP, you note the following. Heart rate's come down a little bit. It's at 108. Respiratory rates also decreased. It's at 24, and the blood pressure's stabling out at 126/88. And finally in that O2 sat up. It's up to 95% now. It's at 15 liters per minute. This may or may not help with altered mental status now that his oxygen saturation is increasing, but reassessment would confirm that. In addition, you note that the patient is less anxious and is using less accessory muscle use. So you are calming the patient down and you're starting to see some improvements. Once you get to the emergency room, and after that, this is where we kind of lose track of patients, but this is pretty much what's going to happen to them, this type of patient anyway. Give your full report. They're going to continue the CPAP and interpret either the 12 lead you hand them or do another one. And what they see is atrial fib, which again is quite common in patients of his age. Little L-axis deviation going on, and there's that left bundle branch block that we talked about earlier when we looked at it. He does have a possible old inferior MI, and his demand pacemaker is firing twice. They do a chest radiograph, and you see pulmonary edema bilaterally. They're going to give him a little bit more Lasix, continue a nitro drip. Actually, they're going to start a nitro drip. Remember, we gave him the nitro tap sublingual, which causes vasodilation. And the patient's going to be transferred to the ICU and discharged 2 days later after he adjusts to the medications. Review. Pulmonary circuit, you got your heart, your atria, your ventricles, pulmonary artery, pulmonary veins, the vena cava, the aorta, the lungs. Here's a picture of the way blood travels throughout your circulatory system. I remember this from EMT school when Lieutenant Grant explained to us this picture that he put in my mind when he made it fireman, simple way he put it, the little pickup truck traveling throughout the body, throughout the circulatory system, transporting little red blood cells on the bed of the truck, and this is kind of the route that it would take. The blood returns to the right side of the heart via the vena cava. You got your superior and inferior. It's pumped to the lungs for oxygenation and offloading of CO2. Go into the right atria, you got your right ventricles, pulmonary arteries, your arterioles, your capillaries, the oxygen, CO2 exchange across the alveolar capillary membrane, the AC membrane. The oxygenated blood returns to the left side of the heart from the lungs to be pumped to the body via the pulmonary capillaries, the venules, the pulmonary veins, to the left atria, into the left ventricle, then out through systemic circulation. So if you just imagine a little pickup truck going that route, it kind of makes it stick in your mind. The normal net movement of fluid across the pulmonary, arterial, capillary walls into the lung interstitium. The arterial capillary BP is greater than the capillary oncotic pressure, which is equal to fluids into the interstitium. The lung interstitium and alveoli are kept dry via the capillary venule oncotic pressure being greater than the venule blood pressure, which is equal to the fluid into the capillaries and the venules. You also have lymphatic drainage. There's a diagram explaining some of that to you. A little of the epidemiology. The CDC reports that about 5 million people in the U.S. have heart failure. 550,000 new cases each year. 995,000 hospitalizations occurred in 2001. About 22% of men and 46% of women develop heart failure within 6 years of an MI. 50% risk of death at 5 years after diagnosis. That's pretty high, 50% after 5 years. Causes of pulmonary edema include increased pulmonary capillary pressure, pulmonary thrombosis, volume overload, left ventricular heart failure, altered pulmonary capillary permeability, acute respiratory distress syndrome, or ARDS you may hear, disseminated intravascular coagulation, DIC, aspiration, infection, and toxins. Causes of pulmonary edema also include a lymphatic insufficiency, decreased oncotic pressure, hypoalbumin, one of these big 5-syllable words, hyperalbuminemia, other mechanisms, altitude, eclampsia, and neurogenic. In left ventricular heart failure, decreased forward blood flow results in backflow of blood. You get the increased pressure in the left atria, the pulmonary vein, the pulmonary venules, and capillaries. The capillary venule BP is greater than the oncotic pressure, results in decreased reabsorption of interstitial fluid, transmembrane movement of fluid from capillaries into the interstitium and alveoli. Here's a picture of an infarct. Picture of left side heart failure. The signs and symptoms you might have are cyanosis, tachycardia, noisy labored breathing, rales, coughing, blood-tinged sputum, a pink frothy sputum, a gallop rhythm of the heart. Symptoms, you'll have dyspnea. The decreased cardiac output results in a catecholamine release, causing tachycardia, cool, pale, diaphoretic skin, and increased systemic vascular resistance. The accumulation of fluid in the alveoli reduces oxygenation. Pulmonary edema equals rales. Hypoxemia develops. You get diffusion through alveolar edema. The O2 diffuses less effectively than CO2. Bronchial irritation can result in bronchoconstriction or the wheezing. Symptoms will include dyspnea on exertion, orthopnea, paroxysmal nocturnal dyspnea, chest pain if an AMI is present, weakness, dizziness, and malaise. Again, some of these are, just beware, some of these are symptoms of pneumonia, so you kind of want to look out for those keys to differentiate the two. Signs, tachypnea, tachycardia, accessory muscle use, productive cough of pink frothy sputum. This is definitely going to let you know it's not pneumonia. If you see this, you automatically are going to be thinking congestive heart failure. Rales and wheezes, cool, pale, diaphoretic skin again. Your S3 and S4 upon oscillation. These are going to be the sounds that the heart's going to be making. The dup, etc., etc. Decrease oxygen saturation in pulsus alternans, which a lot of times we'll confuse with pulsus paradoxus, but the pulsus alternans is simply that waxing and waning between a weak and strong thready pulse. On the ECG, you'll get tachycardia, evidence of left ventricular failure, left ventricular hypertrophy. You'll have a decreased oxygen saturation, and your end-tidal CO2 will normal to slightly decrease secondary to hyperventilation. The elevation indicates hypoventilation, impending respiratory failure. Patient's past medical history might include hypertension, a myocardial infarction, cardiomyopathy, valvular heart disease, and one of the biggest indicators of family history of heart disease. Treatment with pulmonary edema, you need to treat the airway and oxygenation insult as well as the underlying cause. I'll say it again since it's in red. With pulmonary edema, you need to treat the airway and oxygenation insult as well as the underlying cause. If the patient is conscious, place them in a position of comfort, sitting upright. Remember, they're going to have fluid on their lungs, so they're not going to want to sleep. This is one of those people you want to ask them that question with any COPD or CHF or whatnot. How many pillows do you sleep on at night? And a lot of them will tell you, 1, 2 pillows, 3 pillows, or I pretty much sleep sitting up. That kind of lets you know the severity of their disease, kind of an old street trick of figuring that out. You go in and the patient's propped up on 3 or 4 pillows. They're probably doing pretty bad, and they are not going to want to lay back. And if you start to lay them back, they're going to get that look in their eye and beg you to sit them back up. So they're probably going to their position of comfort.